then I'm there.
ನಿಮ್ಮನ್ನಲ್ಲ ವಿದ್ಯಾ ಭಟ್ ನೀವಿರ್ತೀರಾ ಡಾಕ್ಟರ್ ವಿದ್ಯಾ ಭಟ್ಟಿಗೆ ಹೇಳ್ತಾ ಇರೋದು.
Vidya Bhatt ಅವರು ಎಲ್ಲರೂ she has taken responsibility and she is doing 4 workshops for me and she will continue in year 10 also.
Yes.
Yeah.
So there are 20 societies, 4 she will cover this year, 4 next year.
Done.
Yes. Shall we start?
Nagraj sir, namaskara.
Nagraj sir, namaskara.
So when you tell
We
us
will be
to
there
start,
always.
I think we should start now.
We should start. We will start.
Yes.
Yeah. Quite a few of them have joined. I think we'll start. Arun,
are you there?
Yes, ma'am.
Yeah, he's there.
Be ready with the prayer, okay?
Yeah, ma'am.
There and it is YouTube live also. Some people will be
yes,
joining
ma'am.
there, so
Yeah,
no
yeah,
problem.
yeah.
Yes.
Okay.
So we will go live now.
Yes.
A very good evening and namaste to all of you. On behalf of the Karnataka State Obstetrics and Gynecological Association and the Karnataka College of Obstetrics and Gynecologists, we have pleasure in hosting the skill transfer program here today. And knowledge is something that we need to share with everybody. And we have a doyen in infertility, Dr. Chaitanya Nagori, with us here. We welcome you, sir, on behalf of KASOGA and KCOG. I now request the webinar to be opened by invoking the blessings of the Almighty.
कुरुत्वं कल्याणम् आरोग्यं धनसम्पदः शुभं कुरुत्वं कल्याणम् आरोग्यं धनसम्पदः शत्रुबुद्धिविनाशाय दीपज्योतिर्नमोऽस्तुते दीपज्योतिर्नमोऽस्तुते शुभं कुरुत्वं कल्याणम् आरोग्यं धनसम्पदः शुभं कुरुत्वं कल्याणम् आरोग्यं धनसम्पदः.
Bharti madam, you will give the introduction. Welcome address. You're muted.
Only thing is she has to introduce.
Well, on behalf of Karnataka Society of Obstetrics and Gynecology, I extend a warm welcome to our dynamic and ever active President, Dr. Vidya Tobbi. We welcome you, Madam, for this skill transfer program. We have a very eminent personality with us here, Dr. Chaitanya Nagori, who will be talking on male infertility and often laid back and we gynecologists fail to address the male infertility and just try to wave off our responsibility and push them to the andrologists and the urologists. So we have Dr. Chaitanya Nagori, who has made time from his busy schedule to be with us. We welcome you, sir, on behalf of KCOG, the SOGA platform. And then we have the secretary of KASOGA, that is Dr. Rajeshri Paladi, who is, in spite of her busy schedule right there, is there in this program. We welcome you, Dr. Rajeshri, for this program. Thank you. Dr. Vidya Bhatt, the secretary of KCOG and who is the convener of today's program to this program. I also welcome our patron, Dr. M.G. Hiramat, our patron, Dr. Nagaraj, and our dean, Dr. Nima Divakar, and the chairperson, Dr. Muralidhar Pai, to the skill transfer program. We have Dr. Durga Das, a senior member and a past treasurer of KASOGA. Welcome you, Dr. Durga Das. We have eminent faculty and eminent participants who are here eagerly waiting to listen to Dr. Nagori. So I would now request our President, Dr. Vidya Tobbi, to kindly say a few opening remarks.
Thank you, Dr. Bharti, for those all introductory remarks and the warm welcome by you. And I really welcome Dr. Nagori here. He's a really stalwart in infertility, and as Bharti told, he's a doyen of all the whatever things he speaks. It is from his so many years experience. We all know, and we have quite often we have listened to him. So we all eager to listen to him on this topic. That is a male infertility, which is often neglected. We don't touch upon refer all those cases to urologists and we just keep quiet. But how to interpret the semen analysis, which cases to refer, which cases we can treat at our level. I think these tips and tricks we are going to learn from him. So I request Dr. Vidya Bhatt to introduce him. I think there is a long, he has got long CV. I am really sure that he's going to give his experience talk and we will take home messages. I also welcome our infertility chair here, Dr. Shilpa. She had joined and yesterday we had first infertility committee webinar, how to set up an IVF clinic and how to register the ART clinic. That was very informative recently. So she has also joined. So we will listen after the sir's talk, any queries and all, she will be taking over. So I request now Dr. Vidya to introduce Dr. Nagori here, Chaitanya Nagori.
Thank you, Dr. Vidya.
Hearty welcome to you, ma'am. Kasturi, ma'am, our past
Yes.
president of Kasoga. And thank you, Vidya Tobi, ma'am, for the nice opening remarks. And it is my great pleasure to introduce Dr. Nagori. Sir, it was so nice. I tried to call you and you called me back to ask me why I have called you. And with few seconds of my interaction, he readily agreed in spite of his busy schedule. And then he gave the topic and I was really overwhelmed when he said, I'm going to talk on male infertility, which is now the most sorted topic because we find so many problems with the male which has been neglected. We always concentrate as the female on the female as we are gynecologists. So to introduce sir, he is the director of Dr. Nagori's Institute for Infertility and IVF. His work has won the best paper in World Congress, Chicago. He's the first person to start stem cell therapy and have a pregnancy in India and published several papers and in index journals. And first ever Center of Excellence for Ian Donald School of Ultrasound. Sir, you have been creating history. He regularly holds infertility, IVF and ultrasound courses, which I think many people from Karnataka attend to that. And he has also conducted many workshops and lectures in Karnataka. I have invited Sir and Sonal Madam for our workshops here and contributed many chapters and he published textbooks she has authored on infertility, ultrasound for practicing gynecologists. These are all practical tips which we can take from him. And I still remember when he did his IUI workshop long back when I was the vice president in BSOG. Those tips I still follow. How to look for the vascularity and how you see that red ring around the follicle, and then you give HCG, all those things which we can achieve better pregnancy rates. So thank you so much for our honoring our invitation, sir. And thanks for being here. Over to you for your vast experience and deliberation on male infertility.
Thank you very much, Vidya, and thankful to the Karnataka all societies for inviting me for such a good talk. Now, I'll be discussing the medical management of the male infertility, and this is, you rightly said that this is the most neglected portion in the infertility practice. And most of the time when the count is low, the patient is subjected for ART straight away, either for IVF or ICSI. And nobody tries to improve the count. But if you improve the count, then lots of pregnancies can occur. And I'll be discussing, giving you the certain tips how to treat the patient. All of you know that almost 50% of the infertility is solely or partly due to a male factor, and that's why semen analysis is still the gold standard. How it differs from the general medicine. In medicine, history taking is first and the investigation is afterwards. That is the only portion that is male infertility, where investigation is first and history taking is afterwards. So if the semen analysis is normal, unless the patient volunteers for the complaint, there is no need to evaluate further. And the semen analysis is still considered as the gold standard. And if that is normal, then the patient does not require any treatment unless the patient complains of something. So that's why the semen analysis has to be done properly for all the patients. All of you know that the pendulum has swung from 20 million to 15 million in 2010, and 2020 also 21 guidelines, 6th edition, that has also said that even 15 to 18 million is a normal count, motility about 42%, and the 4% normal morphology. I still remember that that was an era that people used to go for ICSI to all the patients with 80%, 85% abnormal. But only 4% normal sperms are required, others are not required. Even if they are abnormal, patient can conceive either spontaneously or with IUI. Now, for a general gynecologist, there is no point in investigating in detail about a male infertility. Only they should remember that only one investigation is important, and that is FSH. Now, there will be 3 permutation combination. FSH, either it will be high, it will be normal, or it will be low. And I'll be discussing, there is no need of any other investigation. LH and testosterone are useful and they can add to the diagnosis, but I will discuss with you that even for a gynecologist, only FSH will suffice in majority of cases. So if the FSH is high, it indicates the primary testicular failure. And in this primary testicular failure, mostly these patients are for AID or adoption. Only little hopes for this patient is a micro TSA, that you can go for micro TSA, you can take multiple biopsies, you can go for a microsurgery. You may find out some seminiferous tubules which are swollen and you may get the sperm. Now here, I would like to advise all the IVF consultants that please don't stimulate the wife, and then at the time of ICSI, you are doing a micro TSA and you may not find the sperm at that time. You request the patient that we have no sperms, that's why can we take from outside semen, and the patient has no option except to say you yes. So I always request that you do first micro TSA, collect the sperm, freeze them, and then stimulate the wife. If you do not get the sperm, please do not. This is my humble request to all, because I've seen a lot of patients who have been told that now we don't have received the sperm, and that is why we are going to use the donor sperm. Now, second permutation combination will be high FSH, normal LH. So whether the LH is high or low, but if the LH is high or low, but if the FSH is high, it indicates always the AID or adoption. Exception is varicocele. When there is a 3rd degree varicocele, there is marginally high FSH is likely. And if you ligate the varicocele, the sperm count will definitely improve. So this is only to be kept in mind, that particularly when the FSH is high, examine the patient or ask for a Doppler. And if you get the 3rd degree varicocele, then that is to be ligated, and then the stimulation is to be done to the patient. So I told you that when the FSH is high, mostly these are the cases of AID or adoption. In some of the cases, you may go for micro TSA, you may get the sperm and you can use it for ICSI, but discuss the cost as well as the result also with the patient. The second permutation combination is the low FSH level. So we have discussed high. Now low FSH level is with the hypogonadotropic hypogonadism. And in this hypogonadotropic hypogonadism, you will always get 2 or 3 patients in your whole career. But the results are fantastic. You treat with HCG 5000 units every 5th day to maintain the testosterone level to a normal. Now, testosterone initiates the spermatogenesis and the FSH maintains the spermatogenesis. That is why in all patients of hypogonadism, you give HCG 5000 units every 5th day till the testosterone level is normal. And then the patient should be given either HMG or FSH highly purified or recombinant FSH thrice a week, that is Monday, Wednesday, and Friday. It should be given. Duration is about 12 to 24 weeks, and you can have a very good spermatogenesis. Even the patient can conceive spontaneously also. Now, Only one thing is with the normal FSH, with the normal FSH, there will be two conditions. Either it may be high testosterone, high LH, and it is very easy to diagnose when the patient enters the OPD. Testosterone and LH are inversely related. But if the testosterone is high, LH is high, then definitely the testosterone will be converted into estradiol, and that will cause gynecomastia. So just by entering the patient to your OPD, there is gynecomastia. Always think of this high testosterone, high LH with the normal FSH. Normally, no treatment is possible. Whatever is available to you for account, either they may be azoospermic or occasional sperm, that you can use it for your IVF or ICSI. Otherwise, no treatment is possible with these patients. So, then normal testosterone, normal LH, and normal FSH. So I tell you that the normal FSH, you can have two things. One is the non-obstructive azoospermia can be present. And second, very important thing, the most common thing in our practice is that the patient is having azoospermia and everything is normal. FSH is normal, LH is normal, testosterone level is normal, Doppler study is normal. So there is no abnormality. And these patients are having a biological failure. What we measure FSH and LH is by the immunoassay. We never measure the bioactivity. And nowadays, immunoassay are not much important because they don't tell you anything about the bioactivity. And there is a loss of bioactivity which is responsible for either azoospermia or severe oligoazoospermia. Here, RIA levels will be normal, but the bioactivity will be very low. And this is because of the inadequate gonadotropin activity. These are the patients where you should treat the patient with FSH 75 international unit thrice a week and HCG 5000 unit once a week. The duration is 12 to 24 weeks. This is Professor Ishidori's regime. Professor Ishidori was from the Sweden. And I was fortunate to listen his talk when he had come to India at Bombay. And he explained this bioactivity. When the bioactivity is very poor, then the patient do not get the spermatogenesis. So these patients are to be supplied with FSH and HCG, and you get excellent spermatogenesis with this regime. Now, when we treat the patient, we have two options. One is the specific therapy. So I've already discussed that the FSH high, FSH low, and FSH normal. Now, when you have to treat the patient, the treatment options are either the specific therapy or the empiric therapy. In a specific therapy, I have already discussed hypogonadotropic hypogonadism. You start with HCG and then you combine FSH to this patient, can be treated. Then there may be hyperprolactinemia, genital tract infection, chlamydia is very common, disorders of ejaculation, immunological, isolated testosterone deficiency, congenital adrenal hyperplasia. These are the specific reasons, and that is why it is very easy to treat this patient. And once you know the diagnosis, then the treatment is very easy. I told you about hypogonadotropic hypogonadism. Then customary teaching, when I was even the teacher or when I was a student, it was taught that the clomiphene citrate does not act in patients of hypogonadotropic hypogonadism. But after 2005, lots of paper came that even in an hypogonadotropic hypogonadism, you can give clomiphene citrate and some of the sperms can be seen in the ejaculate, or even it can be inside also. And with TESA, you can get the spermatozoa. Patient with gonadotropin deficiency, you have to give HCG twice a week. I will discuss in detail in next few slides. All of you know hyperprolactinemia, how to be treated by bromocriptine, or you can, for macroadenoma, you have to go for the surgery for the patient. So what I consider is that the specific therapy can be very well treated. And there are a lot of drugs which can decrease the count, take the history of the patient properly. And particularly, I think Bangalore is the hub for IT people. And there are a lot of people who keep the laptop in the lap or keep the mobile continuously in their pockets. And this can decrease the count, and this should be informed to the patient. Now, we always rely on the empiric therapy. And what do you mean by empiric therapy? A treatment prior to final diagnosis. This is based on the clinical concept and theory without proven efficacy. So somebody tries and then it is strengthened by the different papers then it becomes the conventional treatment. But before that, it is always empiric therapy. And idiopathic infertility is in 25% of cases. Only available therapy for this patient is only empiric because you don't know the cause. And that's why various treatment strategies can come in the picture. So let us discuss one by one. There are a lot of drugs which are available, and I would like to tell you how useful they are and how they can be used even today. The clomiphene citrate is the cheapest drug. A subgroup can be improved. If you read Insler has rightly said that it should be given to all the patients because it is very cheap. And small number of a small subgroup can improve the spermatogenesis. I still remember one of my cousin in 91, 92 when I had given this clomiphene citrate to him. He had only 3 million count, and one cousin also 2 million count. One was treated with clomiphene and second one was treated with clomiphene plus HCG. Both improved the count, spontaneous conception and delivered. So don't underestimate these drugs. You should give it for 3 months, and good number of cases it will be improved. If your colleague has already given for 3 months, then perhaps there is no need to repeat the clomiphene citrate. Now, men with the partial androgen resistance or the mild hypogonadotropic hypogonadism are the best candidates. Monthly follow-up is must. So what you should do FSH level. Clomiphene acts at the hypothalamus, increases FSH and LH. And that is why after 1 month, if the FSH level increases, it means clomiphene is acting. If there is no increase in FSH level, then perhaps the clomiphene will not give you the result. That's why you assess the efficacy of clomiphene through FSH. The study suggested that considering a course of CC prior to surgical sperm retrieval in patients with non-obstructive azoospermia, you get good number of sperms after giving clomiphene citrate. So clomiphene is very important. It should be given to all the patients. Second, the most important is HCG. These are the drugs which are least used by majority of the gynecologists. But this is the wonderful drug I have used for hundreds of patients, and I have got excellent results with HCG. HCG 2,500 to 5,000 twice a week it is given to the patient. I normally give 5,000 international unit to a patient. Twice a week it should be given, that is Monday, Thursday or Tuesday, Friday you should give it to the patient. It is very useful in idiopathic oligoazoospermia. And second, it is very useful after the varicocele ligation. The first reported study on HCG was in 63 and 82, gives 60% improvement. The most unfortunate part because of the invention of IVF, that the companies who used to finance for the drugs which can improve the sperm count has been completely stopped. They finance only for the IVF and the research on the IVF. They don't finance. And that's why I have put these studies, which are so old studies, but remember that it can give 60% improvement. 60% of the patients can conceive and the male may not be at fault at all. And I think this pregnancy rate is much, much higher than IVF. But in spite of that, there are no further studies. Otherwise, so many good analogs would have come by this time and would have improved the count of so many patients. So HCG is very good, particularly if you want to try in oligoazoospermia when there is no abnormality, then always try HCG 5,000 unit twice a week for 13 weeks. I am sure that in very good number of cases, you will get the improvement of the count. Leading cell response to exogenous HCG, more testosterone is produced even in hypogonadism, and HCG is effective prior to decide the hypospermatogenesis. So even if the patient is azoospermic, there is no need to jump for ART immediately and to go for TESA and to go for ICSI. You can give HCG for 3 months, you will have good number of sperm, or perhaps you may get the sperm in the ejaculate also. And this should always be tried to the patient. I'm a fan of HCG. I've used in hundreds of patients and I've got excellent results with HCG. Now, third is the FSH-HCG combination, particularly when it is in idiopathic normogonadotropic oligoazoospermia. When the count is occasional sperm or 1 or 2 million count is seen, I've already discussed that Professor Isidori's regime that you can give it. Second important thing is that when there are so much of aneuploidy in the sperm, the recombinant FSH or highly purified FSH can reduce the sperm aneuploidy, particularly when there is a maturation arrest at the spermatid level. Then the only FSH can be given, and from the the spermatid level, it can go to the spermatozoa. For a primary spermatogonia or secondary spermatogonia arrest, nothing can be done to this patient. So if your testicular biopsy indicates a maturation arrest at the spermatid level, then it can definitely be improved by giving FSH to the patient. It is useful in the subgroup of the patient having normal pituitary function and overt FSH deficiency. Now, this is the current paper, 2023. This is the February 2023 paper, that the FSH is very useful before the sperm retrieval from the testes or from ICSI or from IUI or for natural conception. So FSH improves the count, and the count may improve so that either you can do ICSI, if the count improves more, then you can go for IUI, or even the natural conception is possible. So FSH, which was people used to be in dilemma before, I'm using since more than 20 years. But people who were in dilemma, and there used to be always a discussion in the conferences, the FSH should be given or it should not be given. I had a lot of patients with the severe oligozoospermia who have improved with FSH-HCG combination. And even this 2023 paper suggests that the treatment improves the sperm retrieval. Spermatogenesis is improved by the long-acting, fully bioactive FSH isoform. So even the long-active FSH can be used. Disorders of the testicular function causes decrease in inhibin B and testosterone production that may affect FSH complexity and has an impact on overall FSH biological efficiency. So the damage which has been done to the testis can be improved by giving FSH to the patient. So formerly we used to believe that when the FSH is slightly on the higher side, it is a testicular failure and the FSH should not be given. But nowadays, the treatment says that the slightly high FSH, it is an insult to the testes, and that can be recovered by giving FSH to the patient. So FSH beta subunit gene mutations, if these are inactivating mutations, it may lead to complete azoospermia. FSH determines the number of the Sertoli cells at neonatal and peripubertal age. It decreases the immature forms, and that's why I told you that the spermatid arrest, whenever you get in a testicular biopsy, then or more spermatids in the testicle, in the semen analysis, this can be improved by giving FSH to the patient. It improves hypo and the normal patients both. FSH and testosterone both are required. And that's why we never give direct testosterone. We always give HCG. And that's why FSH and HCG both are required for the patient and can improve the spermatogenesis. This is another paper which has come that 50% of the cases you may get an improvement and 50% you may not get an improvement in the patient. Now, in 1991, Acosta et al. Recommended FSH 150 international units thrice a week to improve fertilization, irrespective of the FSH level. So even with the FSH level, which is slightly on the higher side, then also the FSH 150 thrice a week should be given. And Cochrane review with 412 participants receiving FSH reports, significant improvement in the spontaneous pregnancy rate. So the FSH is a marvelous drug for improvement of the sperm count. Sperm retrieval rate is markedly high in non-obstructive azoospermia, receiving FSH thrice a week. Better responses seen in hypospermatogenesis. FSH plus HCG has better results. But all the world is waiting for the robust evidence from the Ferring trial of FSH, polytropin delta, 12 microgram for 6 months. And I'm sure that by next X-ray, this will be released. The data will be released in the next X-ray, that is only after 2 to 3 months only. And perhaps we will know how the FSH is useful for the improvement of the spermatogenesis. The trial includes the 5 to 16 million sperm and FSH 1.5 to 8, LH 1.5 to 7.5, and testosterone more than 300. They are doing a trial with the delta polytropin. Who is the ideal candidate for giving FSH to the patient? Moderate to severe spermatogenic dysfunction, always give FSH to the patient. Low inhibin B with normal or the subnormal FSH can be given. Decreased testicular volume. In spite of high FSH, there is very important, again and again I repeat this, because we used to believe that whenever the FSH is high, no drug has got any role. But in spite of high FSH, it can stimulate the spermatogenesis in non-obstructive azoospermia. Recent study from Danish population has shown that there is no association was found with polymorphism and the sperm parameters. So that test should not be done. Epigenetic biomarkers may efficiently identify possible responders to FSH treatment. So perhaps in future, by biomarkers, we'll be able to exactly pinpoint which patient will improve with FSH treatment and which patient will not improve by epigenetic biomarkers. But these are still on the research basis, and we are waiting for the future in whom the FSH will 100% act and in whom it will not act. FSH is high as compensated to damage the testicular volume. The rise of FSH stimulates the spermatogonia. Higher dose 300 FSH was given the better results when it is given on alternate days. So instead of 150, the 300 FSH was given. And those who did not respond to 150 FSH in the previous studies probably did not receive a sufficient high dose for a sufficient time. This is 2020 paper, which tells that instead of 150, those who don't respond, then you should go for the 300 units, you can go for it. So just I summarize that FSH 150 unit thrice a week along with HCG once a week is the wonderful drug, and that improves the oligoazoospermia to a normal spermatogenesis possible in all these cases. Androgen masterolone was used a lot, but I just mentioned to condemn it. It has got no role and this should not be used to the patient. Then another drug is the tamoxifen testosterone combination. This is recommended by WHO that tamoxifen testosterone combination should be given to the patient. And the tamoxifen 10 milligram tablet by Temtero tablet by Leica is available. 10 milligram BD can be given. And testosterone undecronate. There are 3-4 companies who are giving 40 milligram tablets where testosterone undecronate can be given. And this, if it is given for 6 months, you can see the improvement of 34% instead of 10%. Now, why I'm emphasizing? Because in periphery, there are a lot of patients who cannot afford gonadotropin. Those patients who cannot afford for ART, then you can try this drug that will improve the spermatogenesis and the patient can have a spontaneous pregnancy or patient can conceive by IUI. That's why these drugs are very useful and are authentically or they are documented in the literature. Zinc are very useful in low testosterone levels with the zinc deficiency. 120 to 220 milligram twice a day for 3 months it can be given. Thanks to COVID, that the zinc is now available as 100 or 200 milligram tablet. Otherwise, it used to be only 35 milligram in all the preparations. And that's why it was very difficult to give zinc to the patient. It was only one tablet that was Infet by Yes Pharmaceuticals that was available and that is still available, that you can give 200 milligram tablet to the patient. It improves accessory gland function, helps in exfoliation of immature cells, and helps in maturation and motility of the patient. So zinc is very useful in oligoazoospermia, very useful in smokers, and very useful after varicose ligation. See, that's why it is very useful for DNA repair and anti-apoptosis. So zinc is a very useful drug. So in our combo preparations, when whatever I prescribe to the patient, one of the condition, one of the drug that is always zinc that is given to the patient. Now I'll be mentioning some of the drugs just as the history, because these drugs are not used nowadays and unfortunately no further research has been done on these drugs. Otherwise, so many drugs would have come out with better products and they would have been very useful to the patient. One of them is ketotifen 1 milligram BD for 3 to 6 months. I have used these anti-serotonin agents in past, that is in my 90s practice. That cyproterone acetate, this is an appetizer, 4 milligram 3 times a day for 90 days and 2 courses are given, it improves the count and motility. And you can see the paper, when the count and motility improves to 33 to 50%, more than 1/3 to 1/2 of the patients can improve the count and motility. What else do you want? So these results are much better, but unfortunate part is that further studies are not done, and that's why these drugs are not used nowadays. Same is for the nucleotide, same is for the captopril, 50 milligram day for 3 months. These are the drugs which are easily available to us, and so much of research can be done on this drug which can improve the count. Pancreatic kallikrein 600 milligram, and this is particularly used pancreatic kallikrein for the IVF patients also for improvement of the oligoesteno. But there are controversial results. So many results they say they are not promising, and people don't use it nowadays. Anti-inflammatory drugs, tetracycline is a drug of choice, or doxycycline 1-BD can be given for 14 days. Please don't try to find out the infection in the semen. It is always better to treat the patient rather than to find the infection. And many a times the premature cells are there, which looks like the pus cells, and patient has taken too many courses of antibiotics because of it. So be careful. Once or twice the treatment is given, the patient is normally all right. And if there is a prostatic infection, then the quinolone group of the drugs are to be given. Another drug for a poor patient who cannot afford much, then the indomethacin 25 milligram capsule 3 times a day. Wonderful drug. It increases the count and motility. So these are particularly those patients who are having oligozoospermia. This is inexpensive, non-toxic, not going to do any harm to the patient. Very cheap drug, and this can be tried to the patient. Teslec or testolecton, and that is anastrozole. Anastrozole, we never use it for ovulation induction. It has no result, but anastrozole is very useful as far as the male infertility is concerned. The anastrozole or letrozole can be used for male infertility, particularly in those patients where the androgen level is low. And whenever the androgen level is low, the testosterone estradiol ratio, which should be 10:1, here the testosterone level is low. So you give anastrozole, the androgen is not converted into estrogen, and that is why the androgen level rises. And that will maintain 10:1 ratio, and it will improve the spermatogenesis. So letrozole 2.5 milligram or anastrozole 1 milligram is a very useful drug, particularly when the testosterone level is low. Then this is autocrine and paracrine system. Autocrine means any drug that is secreted from the cell and it is acting on that cell only. Paracrine means it is secreted by one cell and acts on the other cell. Now IGF-1, IGF-2, EGF and TGF, these are the stimulants, while the CRF beta endorphin system, these are the inhibitors. So naltrexone can counter the CRF beta endorphin system. Unfortunately, naltrexone is not available in our country, but otherwise it can be combined. Naltrexone can be combined with FSH that will remove this CRF beta endorphin system and will stimulate the spermatogenesis. Same way, FSH plus growth factors can be combined, and that can improve the spermatogenesis. Now, after all this drug, the greatest interest now is in ROS. Definitive role of ROS testing in the diagnostic situation remains to be established, although the detrimental impact of ROS on male reproductive potential is now established. Sources of ROS, endogenous is leukocytes, immature spermatozoa, and varicocele. So always remember that particularly in the male infertility, always rule out varicocele. And varicocele, all the patients are not to be operated. 2nd or 3rd degree varicocele with an abnormal semen analysis is to be operated. A normal semen analysis with varicocele, perhaps there is no need of surgery. You can treat it medically, this patient, as far as the pregnancy is concerned. Exogenous source are radiations, toxins, and smoking. So ROS, it has got a physiological role also. ROS is good for capacitation, hyperactivation, acrosomal reaction, and sperm-oocyte fusion. But when it increases in amount, then it causes lipid peroxidation, DNA damage, or apoptosis. So the DNA damage is mostly because of the ROS. And that's why the treatment of DNA damage is antioxidants. Even I don't think that the DNA the fragmentation tests are much useful in practice. Instead of that, you can give antioxidants for 3 months and you can get excellent DNA, non-damaged forms can be got. So in antioxidants, systemic treatment with man with antioxidants reduced the great interest. And antioxidants are the complementary treatment to conventional treatment. This should be remembered that only by prescribing antioxidants, you don't gain much. If you want to prescribe antioxidants, they are much better effective when you have ligated varicocele, when the antibiotic treatment for infection is given, or when there is anti-estrogenic treatment for idiopathic oligozoospermia, then they should always be combined with antioxidants, and that will be very useful. High doses of antioxidants have theoretical adverse effects and so should be used in the low or the moderate doses. With exception of patients with specific vitamin deficiency, any vitamin therapy in a normal man has a questionable role. So no B complex or no vitamins are to be given to the patient. Now, indications of antioxidants, particularly oligoasthenoteratospermia, unexplained male infertility, leukocytospermia. Now, the most important are diabetic patients, smokers, and alcohol and varicocele. These four are most common patients in our OPD, and that is why they should be given the antioxidants. The patients of RPL also, nowadays there are few papers that the antioxidants help in the improvement of the spermatozoa. Now, there are a lot of antioxidants available to us. It is a battery of all the drugs which are available to you, but the most important are tocopherol, that is vitamin E, or you can use astaxanthins. You can have lycopene, you can have carnitine, you can have coenzyme Q. These are the much useful drugs for the patients. All others have the additive value. I consider one by one. It reduces the DNA damage, improves the chances of pregnancy with IUI, reduces the abortion rate, and improves all the parameters. Now, vitamin E, that is an antioxidant therapy. It improves the motility and DNA fragmentation decreases from 22 to 9%. So that's why we always tell that rather than going for all these tests, it is better to give the antioxidants to the patient, and that will be very useful. Astaxanthins, which is much more potent than the vitamin E, and that will be very useful to the patient. And the pregnancy rate has been quoted 23% as compared to 3.6% if the astaxanthins are given to the patient. The dose of vitamin C is 1000 milligrams. So if you want to give, then it should be given as 1000 milligram. Otherwise, it is useless. Same way, vitamin B12. There are so many preparations which have 5 or 10 micrograms of B12, which is useless. And that's why I'm emphasizing on the dose, that when you select a combo preparation, this combo preparation should have the drugs, 3 to 4 drugs in the therapeutic dosage. Then and then only this combo preparation will be very useful. Folic acid 5 milligram per day can be given to the patient. This is for any multiplying cells. The folic acid will be useful. Pentoxifylline improves the count and motility, but there are other papers which tell that pentoxifylline, sildenafil, and other methylxanthils, when administered systemically, give no response. So pentoxifylline is more or less given in the media. It is added in the media and it improves the motility of the sperm. Selenium. Selenium is a very good drug for the improvement of the motility. The dose is 225 microgram, and majority of the preparations contain about 80 to 85 microgram, and that's why the drug is to be given 3 times a day. And 50% of the patients can improve the motility with the help of the selenium. So selenium is also one of the good drug in the combo preparations. Lycopene and carotenoids, you know, all of you, that it is we can get it from tomatoes, carrots, lettuce, and spinach. Improves the motility and morphology, highest ROS squaming capacity, prevents DNA fragmentation, and 4 to 8 milligram. Majority of the combo preparations are 2500 microgram of lycopene, and that tablet is to be given 1 BD, so that at least 5 milligram dose is given to the patient, and that if it is given for 3 months, it is very useful. So even the 2020 report also says that the 5 milligram or 4 to 8 milligram of the lycopene will be very useful. Glutathione 600 milligram intramuscular daily injection is very cumbersome, never welcomed by the patient. It is never popular treatment, and that's why nowadays it is not used. One of the companies have come out with the tablet of glutathione. I don't have personal experience, but still there are no trials available of that oral tablet also. Arginine dose is 4 gram per day. It improves the sperm and motility. Majority of the companies have come out with 500 milligram capsules, and to take 8 capsules per day is very difficult, and that is why this is not the popular regime in practice. Now, L-carnitine and L-acetyl-carnitine, it is a wonderful drug that improves the motility, particularly important role in the sperm cell metabolism. So 2:1 ratio, it means L-carnitine 2 gram and L-acetyl-carnitine 1 gram combination sachets are available, and these sachets are very useful in improving. I think human reproduction, I have 3-4 papers on this, that it can improve the motility of the spermatozoa, and this can be used. Now, the total oxyradical scavenging capacity assay differentiates that which antioxidant is required to which patient. Unfortunately, these assays have not been finalized, and still it is under the research. But the future is not away. Means we'll be able to tell exactly that this patient requires L-carnitine, this patient requires coenzyme Q, and this patient requires some other drug. So that is in the near future, we'll be able to tell this. Sorry. 2 gram plus 1 gram combination. L-carnitine plus L-acetyl-carnitine are very useful in idiopathic oligoasthenoteratospermia and the low-grade varicocele. I told you that grade 1 varicocele should not be operated. Grade 2 varicocele with an abnormal count is to be operated. Otherwise, medically, this can be treated with this. Carnitine is effective in infertile patients with prostatevesiculoepididymitis after the treatment with NSAID. So after the infection, this will be very useful, antioxidants. It improves the erectile function also. And the most important thing to be remembered is that the positive effect does not last after the therapy. So you can't prescribe the drug, ask the patient to come after 3 months, and then you start treating the patient either for IUI or for IVF. It should be continued along when you are doing IUI or when you are doing IVF to the patient, or when you are prescribing anti-estrogenic drugs for the spontaneous conception. It should be given simultaneously to the patient. Now, coenzyme Q, it is a component of mitochondrial respiratory chain, a wonderful drug, and the dose is only 100 milligram BD should be given to the patient. Reduction of CoQ level was found in seminal plasma and sperm cells in infertile man with idiopathic and varicocele-associated oligoasthenospermia. So antioxidants are very useful for varicocele also. And so that's why a low degree varicocele, coenzyme Q, and the L-carnitine and L-acetyl-carnitine are the wonderful drug that can be given to the patient. 100 milligram BD, maximum 200 milligram can be given, but majority of the combo preparations contain 100 milligram, and that can be given to the patient. But here also the beneficial effect does not last for a long time. And that's why whenever you are treating an infertility patient, that should be continued at the same time. Natural, there are a lot of things which are natural sources of coenzyme Q, but in spite of that, there can be a deficient coenzyme Q, and that's why you can give this drug as an antioxidant. Vitamin D, there are studies that have shown that the low vitamin D causes the poor sperm motility, and that's why vitamin D can be supplemented to the patient, and the treatment is much cheaper rather than investigation, and that can be given to the patient. Omega-3 fatty acids are also, it slows down the aging process, and that is why these are also useful for the improvement of the sperm. It protects against the environmental toxins, and that is why it can be prescribed to those patients who are having an environmental toxin in the surrounding. So that is a very useful drug. Alpha-linoleic acid, dose is 1 gram orally. It reduces ROS and oxidized DNA. It improves the Sertoli cell function. So these are some of the drugs which are very useful to the patient. Acupuncture yet to be documented. There are no double-blind studies available. and acupuncture has got no role. It is simply few cases have been documented in the literature, but there are no double-blind studies. Traditional Chinese herbal medicine, not sufficient research has been done, that is on ginseng, astragalus, or sarsaparilla. These drugs are not used routinely because there are no studies available to for the patient. Diet, no processed meat or sweets are to be given. Fruits, vegetable, seafood, and the skim milk, their highly antioxidants are present, and preconceptional counseling, particularly to be done for the diet who are having oligoazoospermia, then they should be advised for the proper diet before starting the treatment. So I have talked about a lot of drugs and how to remember these drugs. So that's why I'm giving you a list of drugs which are very useful for stenoazoospermia. And there are a lot of drugs which are available for oligoazoospermia. Select few and try on the patient. A lot of patients will improve their motility. A lot of patients will improve the count also. And particularly when count and motility both are hampered, then you can have the drug which are common to both. And these drugs can be tried and can improve the sperm count. Just I summarize my talk that the clomiphene 25 to 50 milligram per day for 3 to 6 months, HCG 5,000 unit twice a week, FSH 75 thrice a week, HCG 5,000 either once a week or you can give twice a week also. Tamoxifen 40 milligram per testosterone undeconate 120 milligram. Zinc 100 to 200 milligram BD can be given to the patient. Indomethacin 25 milligram TDS, anastrozole 1 milligram or letrozole 2.5 milligram can be given to the patient. And in the antioxidants, when you are seeing the combo preparations, you should see that 3 or 4 drugs should be present. Vitamin E 300 to 600 milligram daily, selenium 225 microgram daily can be given. L-carnitine plus L-acetyl-carnitine 3 gram daily. CoQ 100 milligram BD is the dose. Astaxanthin 8 milligram. Lycopene 500 micrograms should be given to the patient. Vitamin D 60,000 international unit per week. And alpha-linoleic acid 1 gram can be given to the patient. I would like to tell you only one thing, that the medical management of oligoazoospermia is the most neglected segment of the infertility treatment, especially in this era of IVF and ICSI. But lots of patients, because in our country, neither it is financed by the government, nor it is financed by the insurance company, infertility treatment. And that's why there are a lot of patients who cannot afford the line of treatment, and particularly ART they cannot afford. So in so many patients, you can give medical management, you can convert ICSI into IVF. Occasional sperm, you can get 2 to 3 million count, that is enough for IVF. And all the papers even today tells that ICSI has not the higher pregnancy rate than IVF. So even if you can improve to some amount, the cost to the patient can be reduced. IVF can be reduced to can be converted into IUI, even if you get the count of 10 million. Suppose the patient has got 2 to 3 million count, we don't want 50 or 80 million count. Even if the count goes to 10 million to 15 million, you can do IUI to this patient and then can have a pregnancy. Or if the patient is having 8 to 10 million count, you give the treatment and by and large, it can reach to more than 15 million and it can have a spontaneous pregnancy. Just for the clinical aspect, I tell you that when there are occasional sperms for 1 or 2 million, you use FSH HCG combination. If the count is between 5 to 10 million, then you can use oral drugs like clomiphene and HCG 5000 BD will be very useful drug. And if the count is between 10 to 15 million, then you can use the oral drugs and that will improve the sperm count. So the purpose of this medical management is to make the patient conceive with a less advanced technology. I told you, convert IVF and ICSI cycle into IUI cycle or the natural conception. I just give you, this is the tip of the iceberg. I have plenty of cases where I have improved the count and they have conceived. But this is an eye-opener case I'm giving you. An industrialist of Ahmedabad, 9 years of infertility, semen count 3 million, 7 IVF ICSI failures in this patient. 4 were done in Bombay, 3 were done in Ahmedabad. And this patient came for ICSI to me. I would have been stupid if I would have done the 8th ICSI on this patient, because all 4 ICSIs in Bombay were done by the doyens, or rather who were the pioneers of ART in India. So I cannot say anything more than that. But always remember that, always try to find out what has not been done by your colleagues rather than what they have done. And what I could see, that nobody had tried to improve the count. And I treated this patient with Professor Ishidori's regime, that is FSH plus HCG. The count increased to 22 million, conceived with IUI, a baby boy, and spontaneous conception as the count was more than 15 million after 2.5 years. And the 7 ICSI failure patient has got 2 babies now. So don't underestimate the medical management too far as far as the improvement of the count is concerned. I've got plenty of such cases where, and particularly when we had used all these drugs, particularly when ICSI or IVF was not available. And at that time, we had treated a lot of patients with these drugs, improved the count, and they got conception. So thank you very much for my talk.
Sir, brilliant, sir. That was an excellent deliberation on male infertility. Actually, whenever we try to manage male infertility, what we have seen is we just give them antioxidants and nowhere. Then we think about the urologist. But you have given us a galaxy of drugs of how to manage male infertility, and also how to just make the patient conceive naturally whenever there is a problem with the male sperm count. So one question I want to ask you before I go to the chat box. So whenever a patient comes and we see the semen analysis report and we happen to see asthenospermia, teratospermia, or even oligospermia, is there any set of investigations you ask them to get it done before you actually put them on management?
See, what you ask me, if you really ask me, I will do only one thing. Because a lot of times there are fallacies in the laboratories when you ask for the semen analysis. And even today, even though no IVF consultant will agree to me, but still I consider postcoital test as a very useful test. I will do only a postcoital test. And if I get it by WHO standard, 7 spermatozoa per high power field, then I ignore all other findings.
Oh,
so,
great.
So if you do a postcoital test and if you get the sperm moving after 12 hours of the intercourse, then there is no need of any other thing. That is the final report. So many a times, because it varies from lab to lab and each and every semen analysis have got the different reports. But I tell you one thing, that morphology, only 4% normal sperms are required. More than that may not be necessary, and 32% motility will be enough for the patient. And that's why it is a subjective sensation. It varies from person to person in the lab. And that's why I always go for postcoital test whenever I am in doubt. Or second thing is that you do a semen wash and do IUI and see a sample under the microscope, you will make up that.
Thank you, sir. Thank you for that valuable information. Rajeshri, would you like to take the questions in the chat box?
Good evening, sir. Such an excellent presentation, and we just rebrushed all our knowledge about the medical management of male infertility, which always is a very neglected part of the management of infertility, and taboo that when we ask the male partner to get the test or to take the treatment, that they shy away from this management. Our days in Kasoga have become like katte mane talk. You know, sir, there is a saying in Kannada that every day evening, all the women, they get together and they keep chatting. Our hobby has become chatting about the academics, sir. So
Yes.
this is how our days are going on under the leadership of Vidya Tubbi ma'am and Vidya Bhatt ma'am and the Dean Hema Divakar ma'am and chairperson, vice chairperson, Sajjan sir, Muralidhar Rao Pai sir. They somehow make it possible that we get the best of the faculty to deliver on the topics each evening. The whole day we treat the patient. Evening
Very
we
good.
build the memory to do better for next day patients. So that is how the days are going on, especially post-COVID and with the Zoom connectivity. Sir, I cannot tell how much people have been benefited from your talk today. There have been so many messages in the chat box appreciating your information, that such simple things which we were forgetting, like giving the FSH or the clomiphene and a basket range of nearly 20 medications that you have advised, which can be tried before going on for the IVF and ICSI, and definitely places in the districts and talukas wherein to bring in the the finances. When we say the ICSI or IVF, the patient just disappear away from the outpatient, and definitely this is a ray of hope for many people. And I really appreciate and congratulate your talk. And
Thank
so
you.
patiently
Thank
you have
you.
told everything, whatever was needed. There are some questions in the chat box that with high viscosity semen, how do we treat? This Dr. Shweta Patil has put in a
IUI.
question.
The answer is only IUI.
Okay, sir. And how to go about in a patient where FSH, LH, and testosterone is normal and patient is azoospermic and ultrasound is normal?
I told you that when FSH, LH, and testosterone, all three are normal, and the patient is normal, ultrasound is normal, these are the patients where the bioactivity is poor. And these are the patients you tried with. If you are recombinant FSH, then 75. If you are using highly purified FSH or even the HMG, that is okay to this patient. 150 can be given thrice a week, Monday, Wednesday, and Friday it should be given. And HCG 5,000 units should be given once a week, that is on every Monday. And if this is given for 3 months, at least 13 days, that is 3 months, the remedy. Any drug which is required for male infertility is always to be given for 84 days. Because whatever you get semen outside is always 84 days old. And that's why the minimum requirement of any treatment and efficacy, to know the efficacy of that treatment, 84 days have to be passed.
Correct, sir. Thank you so much for that. And there is one question which is put up by Dr. Shobha Shavi, that does yoga help in these patients?
Anything you can do, but there are no documentation. There are no double-blind studies available that the yoga can improve the count. So this is simply that will improve your health. And when the general health improves, then it can improve everything, including a sperm count. That is only the logic you can apply. But academically, I won't agree to it that just you go on doing an yoga and 1 million count, you are expecting babies after some time. That is not possible.
Correct, sir. So I think you have been in the practice of fertility for nearly 3 decades now. Do you find any change in the pattern of factors or management and approach of the patients? How frequent was this in the, say, 30 years back and now?
Only thing that formerly male never used to volunteer or never used to accompany, but nowadays the practice is that even for the couple, the male always come to the OPD, and whenever they are at fault, they are always ready to take the treatment. But I don't know, some of the district places or even small villages, perhaps they may not agree and they may not accompany the wife, and they may not cooperate also, and at that time the treatment is difficult. So those who are not ready for even semen analysis, we always do a postcoital test and then we proceed further with the treatment.
Okay. Thank you so much, sir.
Perfect, sir.
Minimum sperm count to do the IUI is another question.
1 million.
Vidya, you have to say something?
1 million.
1 million, yes, sir.
If you see the range, it is 0.8 to 5. Majority of the papers, you see that it is 0.8 to 5. But by and large, 1 million is considered as a count. You can do post-wash count, you can do IUI with 1 million. Post-wash count, not the original count. Post-wash count should be 1 million.
Thank you so much.
Thank you, sir. Thank you so much for this brilliant deliberation. I'm sure everybody is really overwhelmed because of this lecture and so much of information we have got. I think we move on to the vote of thanks, and may I request Rajeshri to give away the vote of thanks.
Pranamam, everybody. It's indeed an honor for me to thank such a person who has graced the occasion and addressed the Karnataka College of ONG, Dr. Nagori sir. Heartfelt gratitude for sparing time out of your busy schedule and as always and as enthusiastically always bringing up the talk and so well put up in such a nutshell about all the necessary information regarding the male infertility. My heartfelt gratitude to Vidya Thubbe ma'am, who is always willing and being present there in spite of all her busy work in the medical college, and her commitments towards the Kasoga is remarkable. Heartfelt gratitude to Kasturi Dhonimat ma'am, the past president of Kasoga, who has graced in and made her time feasible. Thank you, Vidya, for asking me to do the vote of thanks, and I express my gratitude to all the people. We had nearly 70 at one point of time, 70 to 80 who had logged in, and I'm sure on YouTube there are many more watching this program. Definitely, we are overwhelmed to receive such a brilliant, masterly scripted talk by Dr. Nagori, and I express my thanks to all the people who have logged in to watch this beautiful talk. Thanks to Arun for coordinating this program, and I'm sure we will come up with more